They call it borderline personality disorder because it's literally on the borderline between psychotic and neurotic. And while most of these people tend to exist, for the most part, in a neurotic state, stressful situations, imagined abandonment, criticism, rejection can send them into a psychotic state, which creates angry outbursts, negative behaviors, which make their greatest fears come true. And teach them some basic tools or tricks in order to cope with the really pressing discomfort of this diagnosis. So, for instance, a technique I'll teach. Usually, the first technique I'll teach a new client after engagement is benign interpretation, which is when anything happens in this world, we interpret it. Right? We all do, regardless of our diagnosis. The borderline has a tendency to interpret everything in the most malignant way possible. For instance, if they're supposed to get a phone call from their partner at 4 o'clock and their partner hasn't called at 4:30, what will run through their mind, their first thought will be, they don't care about me anymore, they left me, they're with someone else. When in reality, the benign interpretation, their phone doesn't work, they're stuck in a meeting, they're in the subway, whatever it might be, is more accurate. So the first thing I teach people is to correct the initial interpretation with the more benign one. And once they do that for a while, they begin to see that 99.9% of the time, and that's not an exaggeration, the benign interpretation is the accurate one. Difficult to learn, but once they see it enough, they start to trust it, and we move on to some higher level skills. Almost all these patients need help with self-soothing skills. They have a tendency to soothe in a self-destructive way. And so one of the techniques I use, which I don't bring out from the beginning, but soon after engagement, is, I kind of ask them how they would take care of the child within them, or their own child, or a friend. And it's amazing, their ability to take care of someone else, to give the right answer of what you would do for that person, is very different from what they would do for themselves. Because my belief, and I'm sure it's not only my belief, is that the borderline patient really essentially inside feels unlovable. Feels like there's something missing, that they're not worthy of love. And so they tend to seek out people who validate that. And if they do find someone who doesn't validate that, they try to sabotage that relationship to keep that myth alive. So they can say, you see, I knew this person was going to leave me. You see, I told you I wasn't good enough. The derivation, again, in my opinion, is early in life, a child is not, an infant or a child, both, is not getting what they need from their parents or caregivers. And so they have to come to a conclusion as to why. Why am I not getting what I need? Well, believe it or not, the healthy infant or child blames themselves. Because in order to blame the world and the parents, it's really a dangerous, talk about anxiety-provoking thought. A child or infant is at the mercy of the world. So early on, the person blames themselves for what they're not getting, saying they must be not good enough to deserve it. They must be missing something to deserve the love and adoration and attention that they're not getting, or the soothing. So that's a myth that needs to be changed later on in the treatment. They need to realize at a certain point that while that idea saved them in their childhood, youth, or infancy, it's now actually killing them. And I tell this one story that I actually learned from a patient of a Buddhist monk on a travel. It's a very quick story, but it illustrates kind of the idea of holding on to an old story, an old narrative about ourselves. So a Buddhist monk's on a journey, and he's traveling, and he's hiking through fields, and he finally comes to a river, and he can't pass the river. So after a while, he fashions a raft out of reeds and grass and whatever else you find on the side of a river. And he paddles his way across the river to the other side to continue his journey through fields and mountains. What should he do with the raft? Now, to the average person, they would say he should leave the raft. It served its purpose. But what's great about the illustration, especially for the borderline, is that raft is that sense that there's something missing, something unlovable about them. That raft saved that Buddhist monk's life. It got him from point A to point B. It was useful. As soon as he gets to the other side of the river, or lake, I forgot which I used, I think it was river. As soon as he gets to the other side of the river, that raft becomes an anchor, a burden. And the visualization of watching that monk hiking through the mountains carrying a raft on his back is funny. And believe it or not, patients get it. And they're like, yeah, I'm walking around with a raft on my back. This might have saved me at a certain point, but now it's a burden. It's not my story. So rewriting the narrative is pretty important. So that visualization tends to get through in patients. So again, along with engagement, benign interpretation, in the confrontation, there's a few other rules of engagement that I give to patients. That are kind of strict rules. One is the no alcohol or drug rule, which obviously don't condone it for anybody, but especially the borderline, it tends to trigger all of the nastiest emotions and insecurity. So the rule is, obviously no drinking, no drugs at all is ideal, but once someone has had a sip of a drink or touched any kind of drug, they are not allowed to process any kind of disappointment or hurt feelings with their partners. They're not allowed to trust themselves. Because most borderlines will tell you that that's when a lot of their trouble starts. So it kind of takes away that piece. And the same is true, I also, another rule of engagement that I suggest is a modified, what I call a 10 to 8 rule, which is between the hours of 10 p.m. and 8 a.m. is not a time to process any disappointment or any fight. A lot of people say don't go to bed angry. Well, you know what? Especially with the borderline, it's better to go to bed angry because they'll frequently wake up not angry. Because the very thing that was bothering them in the moment will be gone the next day. And I've yet to meet the partner of a borderline who has a problem with those rules of engagement. I always say to the patients who have a hard time with it, well, what if it turns out that what was bothering me was legitimate? And I tell them, well, there's no statute of limitations on, tearing your partner a new one. If it's legitimate, you'll be more calm, you'll be more sure about it, and you'll be able to address it in a better fashion. The borderline patient has a very hard time hiding their disappointment or sad feelings. So when their partner asks them what's the matter, I always suggest that they don't say that nothing's the matter because it's so obvious that something is very wrong, but that they say that they're not sure that if what they're feeling is legitimate or not, and that they will let their partner know tomorrow. And yes, a tough skill to acquire, but once the patient really sees that work and sees the outcome of it and sees the lack of destruction that causes, they tend to get on board with it and want to do it. So those are some of the techniques early on that really work and make a big difference for patients. And again, once they start to see a little bit of progress, they kind of want to get on board.
Mm-hmm.